William Bill, topic.
Here you go. Okay, so thank you again, Dr. Lassa, for inviting me. And this was actually a CME lecture a number of years ago, and I was asked to speak on just estrogen, not progesterone, which, if any of you know about hormones, is almost impossible, but I did the best I could. So we're going to be doing a deep dive into estrogen. So estrogen is actually the most studied compound probably in the world, and it is, deeply misunderstood. So let's see, how do we, sure, let's see, well, that's not doing it. There we go. Okay, again, this was a CME class, so disclosures, there's none. Here's the objectives. We're going to go over it briefly, synthesis and function. I'm going to tackle the elephant in the room right away. Does it cause cancer? We'll talk about natural and synthetic estrogens, estrogen metabolism, brain function, deficiency symptoms, dominant symptoms, laboratory studies, treatment strategies, physiologic and superphysiologic estrogen levels in men, and case histories. It's quite long. If need be, we can break it into two if it's too long. But first thing I ask you to do is, which we always ask you to do, is for the next hour or two while we're here, what I want you to do is pretend there's a zipper around your forehead. I want you to unzip it. I want you to turn your head upside down, dump out all your preconceived notions, zip it back up, and then we'll get to go. I learned this from one of my acupuncture teachers way back when, Kiko Matsumoto, if anybody knows who she was. So we'll talk about cases while we go through this. I always find that that's a bit helpful. And this is Marie. Marie was actually my nurse almost 40 years ago now. She was my first nurse. She was 35 or 20, 30, about 30 at the time. And she's now 65 years old. She's got a poorly controlled thyroid, and she's got hot flashes, night sweats, vaginal dryness. She's got long-standing depression, poor libido, and fatigue, and she feels slow. Marie was always a spitfire, always full of energy. She was about, well, we'll have the height and weight in a little bit. She's of Italian extract and a rather forceful lady. I hadn't seen her in a long time, and she actually called me when I moved out to Nevada. It was about 4 years ago. And she said, all of these things were going on. So past history of depressive disorder, hypertension, hypothyroidism. She is obese. She has some urinary incontinence. Her medications are baby aspirin, Lexapro, levothyroxine, 137 micrograms, Prilosec, and I can never pronounce this one. I had a patient when it first came out. She called it Detrol. So this is a Detrol LA, as for urinary incontinence. Her pressure was okay. She's 5'3" and she weighs 215 pounds. The BMI was 37.41. Oxygen was okay. Her reflexes were slow, and she had some lichen sclerosis and vaginal atrophy. What I've highlighted is her estrogen blood levels, serum levels, and that's what we're going to take a look at. And as you can see, a lot of her parameters are off. Her testosterone levels are low. Her estrogen levels are low. Progesterone is low. I'll discuss what EP ratio is in a bit. And you can see her thyroid is off also. And she's got thyroid antibodies. Homocysteine is higher than normal, is usually less than 11. CRP less than 3 is considered normal. Our goal is less than 1. Insulin, our levels that we are looking for is less than 5. And a fasting blood sugar, we want it to be between 65 and 84. We'll also talk about Julia. Julia is a bit younger, and she's 37 years old. She had a history of a traumatic brain injury. She presented for weight control. She has fibrocystic breast disease, fatigue, major depression, gastroparesis, painful irregular periods. She's had her gallbladder out, and she has 4 healed incisions from a lap chole. She has a 18-week size uterus. Julia is 5'7" and weighs 258 pounds. So Julia has some weight to lose also. And so these are two pretty classic cases. One is menopausal and one is premenopausal. Julia is taking, again, another one I can't pronounce. This is Abilify and fluoxetine, so Prozac. She takes oxycodone with acetaminophen, so I guess this is Percocet, and metoclopramide. And this was the workup that we did, and this is fairly standard what we do here. So, and here are her levels, and as you can see, her estrogen levels are elevated, or progesterone is low, and her pregnenolone level is low also, and we'll talk about, again, EP ratios. Her thyroid actually looks pretty good. Her C-reactive protein is higher than Marie's at 5.71. Her vitamin D is pretty low at 17. Homocysteine is 10.8. And IGF-1, which we use as a proxy for growth hormone, has 128. And our goal is about 200 to 250. So those are our two cases. Those are pretty typical of what walks in, at least to my office, with those kinds of issues. So we're going to focus on estrogen. It's the major female sex hormone. It's mostly produced in the ovaries. It is produced in the placenta when the patients are pregnant, and it will also be produced in the adrenal glands and breast and fat cells, especially postmenopausal. It is synthesized via a negative feedback mechanism, and the hypothalamus is stimulated to create gonadotropin releasing hormone, which stimulates the anterior pituitary to release FSH and LH, which directs the ovary and the thecal and granulosa cells to make estrogen, also progesterone. Estrogen has 400 functions. The ones in the blue are the major ones. I'm not going to read them all, but the major ones include increased metabolic rate, insulin sensitivity, dilates small arteries, increases blood flow, particularly in the brain, and that is most important. I'm going to go to men. So back in the day when we first started treating men with testosterone, and they would we would get our treatment total level was at that time when we first started more than 20 years ago, it was 1,500, and then we would give them estrogen blockers to get the estrogen levels to 0. And so we learned pretty quickly that the first part was wrong and the second part was wrong. It decreases a plaque accumulation inside the arteries. It maintains collagen in the skin, and that's easy to see. Anybody does any type of nursing home work, go to the lunchroom where the nursing home is, and you see the elderly ladies. You can see the ones that had hormones are sitting up straight. Their spines are erect. And their skin is smooth, especially over the cheeks, and the ones that did not are all slumped over. They all have osteoporosis, and their skin's all wrinkled up, and they're not nearly as vigorous. Even the ones who had synthetic hormones. It reduces cataracts. It maintains the elasticity of arteries. It reduces the overall risk of heart disease by 40 to 50%. It decreases blood pressure. It decreases LDL cholesterol and raises HDL cholesterol. In fact, this is a strategy. If your patients have low HDL cholesterol, is to treat them with estrogen. And I'll talk about one of the doctors at AMMG who, when we get to it, who actually takes, according to him, he himself takes 7 milligrams of estradiol a day. And we'll talk about the reasons for possibly doing that. Improve cognitive function, improves fine motor skills. It improves mood, energy, concentration, and acts as a natural calcium channel blocker. It also acts as a natural antidepressant, and it helps with the formation of neurotransmitters such as serotonin and dopamine. And it decreases depression, irritability, anxiety, and pain sensitivity. And we're going to talk a little bit about schizophrenia. And there's a theory that low estrogen levels are a predisposition to schizophrenia. Increased in sexual interest. It will reduce homocysteine, wrinkles, and again, protects against macular degeneration. So let's talk about the elephant in the room. If those of you aren't familiar with this picture, this is Lucy the elephant. Lucy was built in 1881 over here on the left-hand side as a hotel. It's in Atlantic City, New Jersey. It's still there. It's down a couple of towns now. It's in Margate, New Jersey, and it was restored in the 70s and 80s. It's now a museum, and it looks out the eyes here. You can go in here. This is the museum is here. You can go up here on the how-do. If you look this way to the right, that's the Atlantic Ocean. If you look this way, it's the town of Margate, New Jersey, and Barnegat Bay is there too. So the elephant in the room is cancer. We all know, estrogen is dangerous. And Premarin, which was the most prescribed drug from 1975 until 2002 in the world. It was given to older postmenopausal females with the adverse effects of blood clots, strokes, and heart attacks within the first year of patients getting Premarin. Oral estrogens cause blood clots. Remember, transdermal estradiol does not, and we'll show you those statistics in a bit. Adding Provera, which is the synthetic progesterone, was even worse, and it increased heart attacks and strokes by more than 50% for those who did not take any hormones at all. And the Provera increased breast cancer, vascular inflammation. Natural progesterone does not. This is just this is just a little bit of chemistry here, and as you can see, this is estrone, one of the estrogen that we produce, or males or humans produce. This is what the Premarin was made out of. It was made out of horse urine, and as the point here is that this is a hormone, this is a drug. These are not the same. And in fact, there's only 3 out of the 10 estrogens that are in Premarin are actually have human characteristics to them. There's also some androgens in there. Natural estrogen is defined as the same chemical structure that we're born with and that we produce. It may or may not come from a plant. Natural estrogen protects against endothelial dysfunction by increasing endothelial nitric oxide. It protects against heart disease, dementia, osteoporosis, and improves insulin sensitivity. Again, another sort of illustration. Remember, there's 3 types of estrogen. We'll go over all 3 of them shortly, but as you can see, these are hormones. These are the estrogens. These are your birth control pills and your synthetics, and they're not the same. Natural estrogen eliminates hot flashes, mood swings, agitation, irritability. It maintains pelvic and genital health. It protects against colon cancer and macular degeneration. Transdermal estradiol does not increase the risk of blood clots. Oral estradiol, which is natural, does, and we stay away from them almost 100%. Usually the only time we have that is patients that are on it and they insist that they're not going to change. So we give them the information that they need. It's cardioprotective, especially to transdermal. It decreases the risks of heart attacks, decreases the risks of diabetes mellitus, and it will increase the lumen. An adequate amount of estradiol for 6 months will widen the lumen of the internal carotid artery by 224%. And again, when we were when we were blocking estrogens in guys down to 0, we were closing this off. This was the EPIC study. This came out 5 years after that WHI study that got everybody into a tizzy. And this was done in Europe. It had 55,000 women, which was about 20,000 more than the WHI, or 30,000 more than WHI study. And what they did is they looked at patients. The baseline is patients who were not treated with hormones, and patients that were postmenopausal, and they were not confined to just synthetic estrogen and progesterone as the WHI study was. And so what they found is that patients that were just given estrogen or synthetic estrogen, this is Premarin here, had on average a 20% increase in breast cancer risk versus no hormones at all. Over here on the right, this is patients given Premarin and Provera, sometimes Prenpro. and they had a 40% increase in breast cancer incidence versus no hormones at all. And in the center here, this is where your natural estrogen, your estradiol and progesterone, it was an oral progesterone, it was a transdermal estradiol, and what we see is we have a 10% decrease in incidence of breast cancer versus not treating the patients at all, not having any hormones, a 50% decrease from the Prempro crowd, and a 30% decrease from the Premarin crowd. So the natural estrogen, natural progesterone, that's what you want to use. And I think that should be pretty well known by now. And this was a study done in 2007. So this isn't really anything new. But, again, I mean, I don't know, where any of you are, but, the so-called experts here, at least in Reno, they really don't know anything about this at all. And you should hear some of the stories that I hear. So this was another study, 23,000 women treated with biased, with or without progestins. And there was a 28% decrease in cancer mortalities after 3 years with these patients, and a 23% decrease in all-cause mortality with patients treated with natural estrogens. So long-term survival, this is an 11-year study of long-term survival with patients who had breast cancer. Those that had no hormones, there was a 33% mortality rate with those that had no hormones post breast cancer. Those that were given testosterone, an estrogen blocker, and progesterone had an 87% survival rate, or a 13% mortality rate. And those that had natural estrogen, natural progesterone, and natural testosterone had a 94% survival rate. So you can see there's a big difference between patients that are treated with hormones and that patients that are not. And so we're really doing them a disservice by withholding the hormones. And it all came about because synthetic hormones were de rigueur. That was what was used, and they got confused with the natural ones. And in fact, for the longest time, the Endocrine Society and even today, the North American Menopause Society says there's no difference between the synthetics and the natural estrogens. With tons of evidence in their face, they just don't seem to care. Synthetic estrogen increases blood pressure, triglycerides. This is where you get gallstones. You'll get elevated liver enzymes. You'll get elevated sex hormone binding globulin, which will bind greater to testosterone than to estrogen, and you'll get a decrease in testosterone with higher sex hormone binding globulins. It also interrupts tryptophan metabolism, and you'll get a decrease in serotonin, which leads to brain fog and depressions and all that goes along with that. It will lower growth hormone. It will increase C-reactive protein, your inflammatory markers, and it increases carbohydrate cravings, which feeds into the weight gain with the synthetic hormones. Just a brief word on progesterone. So progesterone will help, natural progesterone again, will help maintain pregnancy, improves mood, it improves sleep. It's a diuretic. There's no effect on blood pressure. It maintains estrogen-induced arterial dilatation. It improves lipid profiles, and it will reduce estrogenic stimulation of the breast and prevent breast cancer. Synthetic progesterone does the exact opposite. It can cause breast cancer. It increases estrogenic stimulation of the breast. There's increased incidence of heart attacks, increased incidence of cancers and strokes with synthetic progesterone. And again, natural progesterone, and then here are the synthetics. And again, the point here is that these are drugs. This is the hormone. Dr. Halasa, can you make me not the host here, because this thing keeps flipping on, and I have to. It's a little disconcerting here. Okay. In this study, low progesterone was found to be the causes of breast cancer, not the estrogen. So these are 722 patients followed up for 33 years. So it was done over a long period of time. These were patients that were infertile and had luteal phase defects and progesterone deficiencies. There was 10 times the incidence of death from all cancers and 5.5 times the incidence of premenopausal breast cancer in patients that had low progesterone. So this is an absolute in our practice. We never, ever, ever use estrogen without progesterone, and we make our patients pinky swear to it. And then if you're prescribing estrogen and they don't want progesterone, then we're going to go to something else, because we're not going to give them the estrogen. You're just playing with fire when you're doing that. So please don't treat estrogens with progesterone. This was a letter that I have that I sent to, I get all the time from insurance companies, even though we don't take insurance anymore. They're not going to pay for, they have to use 6 different synthetics before they'll grant the natural. So these are the references I have for that. So when you get these slides, these are the references. It's a 3-page letter. If you want the letter, I can send that to Dr. Halassa to send it on to you. You can see there's 25 references in a 3-page slide. And usually the answer I get back was, your practitioner sent us some information. We don't care. That's the usual answer there. So anybody who's prescribing hormones in any way, shape, or form needs to know this chart backwards and forwards. This is your steroidogenic pathway. And we're going to follow this along as we follow the estrogen synthesis and metabolism. Remember, it all comes from the taboo stuff that we told everybody not to eat in the 80s and 90s was cholesterol, and that's sort of the substrate for all of the hormones. And you can just imagine the statins work up here in this part of the pathway that's off the chart here. And as you can see, just put a big X through here, and that's what happens when you get your statin levels up high enough. Just put a big X through all of the hormones, and we're dealing with usually more mature people anyway. So as for natural estrogen, there's 3 types: 1, 2, and 3. I always tell the patients this: estrone, ESTR, estrogen, ONE, 1. Estradiol is 2, estriol is 3. And they are distinct molecules. Estrone, E1, this is mostly your postmenopausal estrogen. It's produced by the adrenal glands and fat tissues, and this is your cancer-causing pathway. Increased high levels. It causes increased levels of breast cancer, and increased levels of heart attack, strokes, prostate cancer in men. It's thrombogenic. You'll get some acne here. The breakdown products are the 2-hydroxyestrone pathway and the 4 and 16-hydroxy pathways. The angel of mercy, so the good pathway is the 2-hydroxy, and the 4 and 16-hydroxy. That's your angel of death. You want to steer your patients away from that. You can get these levels in a urine test. Probably is the easiest way to do that. That Dutch test will give you the breakdowns on these on the metabolism automatically. Serum estrone levels, if they're greater than 100, and quite frankly, if it's greater than 90 picograms per milliliter, we'll treat these patients with 7-keto DHEA. We start at 25 milligrams at bedtime. We'll go up to 100. What this does is it sort of fools the steroidogenic pathway into taking the estrone out of the circulation. I liken it to those of you again, how I explain it to the patients. If you remember the movie Animal House, the last scene where the frat brothers take over the marching band, and they lead it into a off the main highway and into a brick wall. And that's what 7-keto DHEA does. It takes the estrone and it renders it inert. Many years ago, Dr. Oz, he touted 7-keto DHEA as a weight loss supplement, and you will get a little bit of a weight loss component with it. And again, what it does is it decommissions estrone. Estrone has a tendency to accumulate fat in the belly, and so when we decrease our estrone, we're going to get decreased visceral fat. and it will you'll get a bit of a weight loss with it. I've not found it to be a huge weight loss, but a little bit. You will get some. Natural estrogen eliminates hot flashes, night sweats. It restores cognitive function. It maintains thickness of the skin and hair. It maintains genital and pelvic health, vaginal lubrication. It protects against colon cancer and macular degeneration. Estradiol, E2, that's, this is the main estrogen, will increase HDL, decrease LDL, decrease triglycerides. This helps maintain bone structure, bone function, increases serotonin, decreases fatigue, works as an antioxidant. It helps maintain memory. It helps absorption of calcium, magnesium, and zinc. Estriol, that's his pelvic estrogen. It's 80 times weaker than estradiol. This does displace estrone from the estrogen receptors, and it protects against breast cancer, but there's no heart, bone, or brain function with estradiol. Estriol helps maintain pregnancy, it maintains vaginal lining. It occupies at the like I said, the estrogen receptor sites of E1, and eliminates the estrone. It helps control menopausal symptoms, and again will help a little bit with HDL and decrease LDL. Reduces pathogenic bacteria, it restores the vaginal pH, helps prevent urinary tract infections, and it aids in maintaining a favorable microbiome. There's two types of receptors, alpha and beta. Alpha increases cell growth. Estrone activates receptor alpha selectively in a ratio of about 5:1. Estradiol will activate estrogen receptor beta and alpha, and estriol will bind to estrogen receptors beta in a ratio of 3:1 and aids in breast cancer prevention. The two major pathways that will, or the three major pathways that estrogen will metabolize to, the 2-hydroxy and 16-hydroxy estrone, and a minor one of 4-hydroxy estrone. We want to go to the 2-hydroxy estrone. This is our go-to here. This is where we want to sort of push our patients. Methylation is one way to do it. The 2-hydroxy estrone does not stimulate cell growth. It blocks the action of the carcinogenic estrogen products. It protects against cancers. You can do that. I've never done this. I found this somewhere. This sort of urinary 2-methoxy to 2-hydroxy estrone ratio will tell you about methylation ability. Quite frankly, homocysteine will do the same thing. It's much easier to obtain. You can get it again in that Dutch test, urinary, the urinary measure. To raise the 2-hydroxy estrone levels, moderate exercise, cruciferous vegetables. Remember, be careful with cruciferous vegetables, though, if the patients have thyroid problems. The cruciferous vegetables are goiterogenic, and they will slow the thyroid down. I don't have a good way to balance that, except you just have to play with it, and everybody's an individual. Some patients can take cruciferous vegetables if they have thyroid issues and they're postmenopausal and they're just fine, and some are not. Flaxseed, soy, kudzu, and the broccoli derivatives, indole 3-carbinol, and DIM, and sulforaphane. Sulforaphane will increase dihydrotestosterone, by the way, and you'll get an increase. You'll get an increase in hair growth there, and also for guys, if you use sulforaphane, you'll get increase in prostate size. Omega-3 fatty acids, the B vitamins, methylated B vitamins, TMG, betaine, rosemary, turmeric, and high protein diet will all raise 2-hydroxy estrone levels. Estrogen enhancers, again, include the things that we already discussed. Black cohosh and chasteberry usually come as a combination. Dong quai is a Chinese herb. Maca is another herbal remedy that will enhance estrogen and lower testosterone. Boron will bind to sex hormone binding globulin, and so you'll get a lessening of the sex hormone binding globulin and more free estrogen and also free testosterone. DHEA will again is one of the precursors of estrogen and testosterone. So DHEA, you can get that over the counter. Usually for females, 10 to 25 milligrams is the dose, never more than 25, at least in our practice. 50 to 100 for men. Omega-3 fatty acids, again, the TMG, rosemary. Homocysteine levels are a proxy for the methylation and the 2-hydroxyestrone pathway. Optimally, we want that to be less than 10 micromoles per milliliter. Low ratios, the 2 to 16 hydroxyestrone levels are associated with lupus. And again, you can see that in the urine test. Methylation support, again, to some more things to again support your 2-hydroxyestrone pathway. Stress reduction, SAM-E, methionine, your methylated B vitamins, also folic acid as folinic acid, and betaine TMG. The 16-hydroxy pathway, this one's down here. That's one of the ones you want to try to avoid. This is the estrogenic breast cancer, obesity, hypothyroid pathway. Omega-6 fatty acids, elevated inflammatory cytokines. So you do get one, again, usually we get this in the urine test. When you see this, we want to block that pathway as best we can. 4-hydroxy is actually directly damages DNA. This was where you can't get from your birth control pills and your synthetic estrogens. Premarin increased 4-hydroxyestrone and is usually present in the with methionine, folic acid deficiency, and again, uterine fibroids. Endocrine disruptors is always a big topic. Dr. Patel is probably better expert than I am. So patients that are obese, have weight gain, have a decreased 2-hydroxy to 16-hydroxy ratio, your xenoestrogens, so pesticides, synthetic hormones fed to animals, plastics, cosmetics, alcohol, and then antibiotics. Too many antibiotics disrupt the GI flora, cause leaky gut and inflammation. Brain function, estrogen increases blood flow to the brain. I mentioned that earlier. It increases blood sugar and oxygen in the brain. It is directly related to neurotransmitter quantity and function, sensitivity to nerve growth factor. It's associated with greater ability of speed and dexterity, the availability of acetylcholine, and long-term memory. Decreases in estrogen you'll find in patients with Alzheimer's beta amyloid plaque, and also that those that are easily distractible. Protects the neurons. It keeps the blood-brain barrier intact. It's a natural antioxidant, and it's a signal for progesterone receptors. I mentioned psychosis earlier. Estradiol influences dopamine, serotonin, and glutamine. And there's a pretty strong evidence that schizophrenia has a strong hormonal component to it. And so especially patients that are treatment resistant, anxiety, depression, and then this severe mental illnesses, really need to take a look at their hormones. Estrogen and cognition, so estradiol, testosterone, and IGF-1, which remember is the usable portion or the active portion of growth hormone, are independent and selectively have effects on cognition. 17-alpha estradiol is neuroprotective after a stroke and oxidative stress, and we've had some really good patient recovery after both hemorrhagic and infarction type strokes, with improved memory and increased recovery time by up to a year almost. Pre-existing traumatic brain injury, so-called pre-existing low estrogen, i.e. menopausal patients, and also young girls, before puberty, are susceptible to developing PTSD. Higher estrogen levels are protective. Estrogen lowers the risk of PTSD after trauma. It modulates pain. It's one of the strongest predictors of acute mortality and poor long-term outcome. And the CSF estradiol is lower after a traumatic brain injury within 96 hours of even a mild traumatic brain injury. Again, maintains cerebral blood flow. It prevents apoptosis or cell death. It acts as a growth factor, and it decreases the risk and onset and progression of neurodegeneration and Alzheimer's disease, aids in recovering from strokes and traumatic brain injury, and helps prevent neuronal blood loss, neuronal loss in the CNS. Symptoms of estrogen deficiency: hot flashes, night sweats, brain fog, belly fat, memory loss, decreased libido, vaginal dryness, loss of femininity, so-called fear of aging, dementia, fatigue, low energy, depressed mood, stress incontinence, urinary tract infections, osteoporosis, cerebrovascular disease, peak suicide age. I got this from Dr. John Donaldson, who's the chief of psychiatry at UCSF. He gave us, had to go to the suicide lectures that the state mandates, and he stated that peak suicide years for females are ages 50 to 65, and he associated it with the loss of estrogen. When I asked him why they didn't do anything about the loss of estrogen, and they were using antidepressants, and he said they didn't really know anything about it. So that's the psychiatry department at UCSF. Physical characteristics of estrogen deficiency: pale, hollow faces, dry eyes, wrinkles, just sort of dry, dried up look. Carotid atherosclerosis, muscle wasting, breast atrophy, tooth loss, and itosis, lethargy. This hair loss here is in the vertex. So it's not in the hairline itself, it's behind the hairline, and it's in the vertex. This is pretty pathognomonic of estrogen deficiency right here. Small wrinkles around the eyes, and especially, and everybody pretty much knows this, above the lip. You get wrinkles between the nose and the upper lip. It's either from smoking for a long period of time or estrogen loss. That's where it comes from. So patients that are in their 50s and 60s and they come in with these lines and they say, I don't know where it came from, I didn't smoke. That's what it is. They have low estrogen levels. Mucosal wasting, decreased lean body mass, increased fat mass, thinning hair, especially in that vertex there. Maxillofacial inflammation. They get the jawbone receding, headaches and fatigue. Too much estrogen dominance now. So this is too much estrogen relative to progesterone. We see this in women of all ages. We'll particularly see it in young women in their late teens, early 20s. Usually part of a process that we call polycystic ovaries, and we're going to look at that fairly extensively in a few minutes. It's part of the effect of the synthetic estrogens, xenoestrogens, and or a progesterone deficiency or progesterone resistance. The common denominator is that too much estrogen is inflammatory. Estrogen causes cysts. Too much estrogen versus progesterone causes cysts, and it affects the organs that are most likely to be affected by our hormones. So breasts, uterus, and ovaries, and gallstones. So patients who have frequently will come in, a 40-year-old female, and she'll be having agitated, irritable, can't sleep, hot flashes, night sweats, and she'll tell us that she had her gallbladder out 10 years before. And I'll tell her, she doesn't have to tell me, did you have a mammogram? Yes. And I'll tell her, let me tell you what it says. It says dense breasts. That's estrogen excess. There's an increased incidence of autoimmune disorders, breast cancer, breast tenderness, fat around the hips and thighs, fatigue, fibrocystic breast disease, breast cysts, breast lumps. Gallbladder disease is associated again with estrone. We talked about that. Endometrial cysts, so endometriosis, endometrial cancer. Uterine cysts, we call them fibroids or uterine cancer, and ovarian cysts or ovarian cancer. They're all interrelated. Magnesium deficiency is usually associated with this. So you get muscle cramps, mood swings, uterine cancer, uterine fibroids, and you also get peripheral edema, bloating, and water retention, infertility, irregular menses, and irritability. Etiology is usually an increase in aromatase production. We get an increase in estrogen, particularly estradiol. obesity, those who are overweight will have increased levels of aromatase in their breast tissue, and white adipose tissue, which is the organ tissue, which will cause inflammation. Increased in the white adipose tissue will result in an increase in prostaglandin expression, an increase in COX-2 inflammation, with increased aromatization and estrogen production. You get an increase in pro-inflammatory mediators, particularly NF-kappa beta, TNF-alpha, interleukin-1, and prostaglandin. And it's all a cascade, and results in excess estrogen production from inflammatory mediators. Endocrine disruptors, we mentioned just briefly, 92% of BPAs found in 92% of US men and women. It induces COX-2 expression. It affects methylation and can increase breast and prostate cancer. And it's associated with endometrial hyperplasia, polycystic ovaries, ADHD, fibroids, sexual dysfunction, breast cancer, and then going down that 4-hydroxy to 2-hydroxy metabolism, an increase in inflammation and recurrent miscarriages. Polycystic ovarian syndrome. So what most think of it is polycystic ovaries is more than one cyst in the ovaries, and it's really not quite that. It's the most common endocrine disorder in women of reproductive years. It affects 4 to 10% of women in the US. It accounts for 75% of the women that have amenorrhea, 85% of the women with androgen excess and hirsutism. And we can control it, but technically it's not curable. Etiology is chronic anovulation. There are some genetic markers that are common. You'll get an increase in LH, a decrease in FSH, which will result in excess testosterone production via androstenedione. And then you get that aromatase activity from the testosterone and increase in estradiol. The technical definition is oligo-ovulation or anovulation, clinical signs of androgen excess, and more than 12 cysts or follicles in the ovaries at 2 to 9 millimeters. I've seen some reports where they say you need 8, and some that you need 12. It's more than 1 or 2, so you need a lot of ovarian cysts to be polycystic ovaries. That's sort of the technical definition. The practical definition is amenorrhea, oligomenorrhea, elevated estrogen symptoms, and blood sugar. And then you end up with you get insulin resistance and blood sugar abnormalities. The patients are usually overweight. BMI is usually greater than 30. And then they get testosterone excess symptoms, which is oily skin, oily hair, skin breaking out, especially on the neck and shoulders, acne. They can get alopecia. They can get male pattern baldness or female pattern baldness, but more male pattern baldness. And then they get insulin resistance all the way to frank diabetes, possibly or hypoglycemic symptoms if you get them early enough. And usually they have higher blood pressures. With elevated blood sugars, they get these skin tags and darkening around the neck, which acanthosis nigrans. Again, irregular or absent menstrual cycles and a lot of infertility. And there's usually irritability and depression. This is just a schematic of testosterone metabolism, so you can understand that what we're looking at actually will make some sense. So testosterone, remember, I showed you that chart before. We had your cholesterol metabolizes to pregnenolone, which then will metabolize to DHEA and androstenedione. Androstenedione will metabolize into a testosterone. Testosterone via 5-alpha reductase will convert to dihydrotestosterone, and that's where you get your prostate, skin, hair issues. Testosterone itself will produce sperm and muscle mass and bone formation, and it will also aromatase into estradiol, where you'll get increased fat. It will produce, that's where your brain cells come from, though. liver and testes in males, bone thickness, HDL, LDL ratio, brain function, and breast proliferation. So polycystic ovaries, you're going to see all of these symptoms. Again, excess testosterone, blood sugar abnormalities, so acne, hirsutism, particularly in the low back, in the upper lip, and the chin, but you'll get alopecia on the scalp, and that has to do with 5-alpha reductase and dihydrotestosterone production as the testosterone itself metabolizes. You'll get chronic anovulation, the polycystic ovaries, low libido, sexual issues, abnormal hormone receptors. Other effects is the hyperinsulinemia, and there you get your insulin impaired glucose tolerance, dyslipidemia, visceral obesity, overweight, obese patients, hypertension, endothelial dysfunction, and insulin resistance and fatty liver. Inflammation here is the driving force, and again, your white abdominal fat with altered adipokines, insulin resistance, altered immune cell reactivity, impaired circadian rhythm, and dysbiosis in the gut, mouth, fat, vagina, and skin. Insulin will decrease sex hormone binding globulin, which will increase circulating testosterone. Insulin and luteinizing hormone will increase androgen production in the ovaries, and then you'll get the decrease in that 2-hydroxylated pathway, and will devolve into the 4 and 16 hydroxy pathway, the damaging pathways. Estrogen is due to a partial peripheral aromatization of androstenedione and testosterone, and we end up with that estrogen dominance. What you'll see in laboratory studies, increased with polycystic ovaries, is increased testosterone. Again, androstenedione, usually we'll find that in those urine tests. Insulin and insulin resistance levels will be high. LH to FS ratio will be elevated versus normal. Higher blood pressures, DHEA will be elevated. Higher estrone levels, and estrone in the premenopausal patients should be very low to almost zero. And you'll have them in the 40s, 50s, 60s. That's too high for an 18-year-old or a 22-year-old. Elevated also IGF-1 levels, decreased sex hormone binding globulin, adiponectin, and progesterone. Symptoms, again, we mentioned these: acne, deepening voice. I don't really see that often. Irritability, moodiness, and anger, the so-called road rage. Again, you see that once in a while. I don't really see that often. You see unwanted hair, again, usually on the lip and the chin, and in the low back. Irregular menses, decreased HDL cholesterol, anxiety, fatigue, hypoglycemia, sugar cravings, insulin resistance, weight gain, and increased incidence of hair growth. Diet. You want a little bit higher carbohydrate diet here, and you want a nice sort of array of healthy fats, nuts, seeds, olives, coconuts are good, avocados are good, prebiotics, probiotics we usually prescribe. I'll show you a regimen in just a minute. Green leafy vegetables and root vegetables. You want to limit the protein. Again, higher protein diets will increase testosterone levels, especially animal protein. So you want to really limit the protein here, and you want to try to avoid as best you can animal protein. And again, the usual refined sugar, salt, sugar, alcohol, food intolerances, and caffeine. We want to take a look at the microbiome. So we always do a stool test for that. And we're looking for barrier integrity. We measure a zonulin level. We look at the natural bacteria and if there are any unnatural bacteria, viruses, parasites. And our goal is to reduce inflammation. You want to look at an alkaline diet. So all the way over on the right are the most alkaline foods, and then all the way over on the left are your acidic foods. And again, these are no surprise: alcohol, processed foods, milk, cheese, ice cream, white flour, white sugar, dairy. Those are the bad guys. Treatment. polycystic ovaries. This is the sort of gynecological doctor treatment. Spironolactone will actually do a pretty nice job, 50 to 100 milligrams. You can start at 25, but usually you need 50 to 100 of removing the side effects from excess testosterone. So oily skin, again, oily hair, and acne spironolactone does a pretty good job. Remember, it's a potassium sparing diuretic, although it's pretty weak. We usually dose this in the morning because it is a diuretic, and you have to watch the patient's blood pressures, and it's again, and their potassium, especially if they have any kidney issues. Cimetidine, don't use that often. Ketoconazole works quite nicely, even though it's an antifungal agent. It also is quite good for helping to restore head hair and remove body hair, so that works quite nicely. You can get it in in oral form, or you can get it as a shampoo. Also, you need 2% shampoo for that. I don't really feel comfortable with the gonadotropin blocking agents. So leprolamide, I'm not one that I don't use that. Finasteride has a lot of side effects, and we have a whole lecture on post-finasteride syndrome. You have to be very careful with that, and it will help grow hair. It will help with block some of the excess estrogen symptoms, but there's a lot of side effects with it. There's sexual side effects. There are what they call general side effects, which amount to, again, excess testosterone and excess thyroid symptoms. And then there's a lot of mental issues also. There have been more than 200 suicides have been traced to low-dose finasteride in young men ages 18 to 43. So you really need to be careful with that. We do use it for hair lotions. Locally, it doesn't seem to have that kind of effect. But the oral finasteride, you really need to be careful with. Again, progesterone, we can use that as to balance the excess estrogen. A low glycemic diet, estrogenic birth control pills. I don't prescribe birth control pills. That's if somebody wants to, that's fine. But that's those are synthetics. Those are off limits as far as I'm concerned. HCG, if we can get it these days. Ovarian wedge resection and laparoscopic ovarian drilling. I was an OBGYN resident. We actually did a few of these, but it was 40 years ago. I don't really remember exactly how it was done, but we did do this back then. This is a 4-week anti-inflammatory sort of reset diet. It will help support the patient's detoxification and hormone metabolism. So we're going to use DIM, so that our herbal estrogen support agent, and calcium D-glucarate, 2 a day. N-acetylcysteine will have some anti-testosterone effects along with liver detox effects. Probiotics, and we like the spore probiotics now. So either I can use trade name, either Megaspore or Orthospore. We get that one from Orthomolecular. It's a little bit less expensive than Megaspore. Prebiotics with L-glutamine and fish oil, a good quality fish oil, 1 gram twice a day. Myo-inositol, I'm going to talk about that in a minute. This will restart ovulation. Berberine will improve your insulin resistance, and it will help lower LDL cholesterol. And then those of you who've been paying attention to the GLP-1 literature and all, berberine is now, we've been using it for 20 years. It's now considered quote unquote nature's Ozempic. I've not really found it to be helpful in any doses that we've used for weight loss. We do use it as sort of a help with weight maintenance, however. Again, N-acetylcysteine, 900 milligrams up to 3 times a day. Vitamin D, and if you don't know how to dose it, I don't dose it this way. Our goal is 50 to 80, and then for every 1,000 units of vitamin D, use D3. It should increase your vitamin D level by about 8 points. It takes 2 to 3 months. So if your and our goal is anywhere from 50 to 80, midpoint is 65. So if our patient has a vitamin D of say 35, if we use 4,000 units, 4 times 8 is 32, and 35 is 67. That's pretty close to dead center. Again, EPA, DHA, 1 gram twice a day. And then these are some of the, and I'll go over them in a little bit. These are some of the remedies that we use for insulin resistance. So chromium, alpha lipoic acid, which is also helps with diabetic peripheral neuropathy. You need 300 milligrams twice a day, though, for that. Cinnamon will improve insulin resistance. Quercetin is an anti-inflammatory and antioxidant, as is curcumin or turmeric. And we use a lot of resveratrol. In fact, resveratrol and berberine. Resveratrol, you need a lot, though. You need 100 milligrams, which most of the supplements don't have. And you need trans resveratrol, not cis resveratrol. So the trans resveratrol, 100 milligrams, and berberine, 400 milligrams, 2 of them twice a day. We use that for our maintenance on our weight loss programs. It doesn't, patients don't usually lose weight on that, but it keeps them from gaining it back. Melatonin up to 10 milligrams, and that will actually lower testosterone levels a little bit also, and then nitric oxide. So again, these are some of the remedies here. It's just sort of listed. Those 2 schedules I showed you was a 4-week schedule. Other ones to point out here, spearmint tea. We use this. It's quite effective in lowering testosterone levels. You need 1,000 milligrams a day. You get 700 milligrams of spearmint in 1 tea bag of Lipton. So 2 Lipton tea bags in 1 cup of water, 5 days a week. It does get a little bit old. You can use peppermint also. You will decrease total testosterone levels by about 20% in about 4 to 6 weeks. We use this all the time. It works. It absolutely works. You can use fancier teas if you want, but you can get Lipton pretty much anywhere. Myo-inositol, I'm going to give you a little bit more information on that. Is quite effective again in inducing ovulation. And again, we mentioned pretty much all of the other remedies that are here. Insulin resistance, again, just as to reiterate things. So again, B complex, we want to use the methylated B vitamins, coenzyme Q10, vitamin C, manganese. There's your myo-inositol again, GABA, N-acetylcysteine, cinnamon, Gymnea sylvestre, and usually come as a combination. We like one from Zymogen called Syndrome X, Cindrome X, letter X. That's one we like. There's another one from Numedica called Synergy, Cinnergy, and they have cinnamon, Gymnea sylvestre, and they got 2 others that are escaping me at the moment, one beginning with a V. For acne, so saw palmetto, and again, this is half dose of the male dose for that we use for prostate enlargement. So for females, half dose, 240 to 260 milligrams once or twice a day. Metformin. Now, just be forewarned, especially patients that have polycystic ovary patients. Usually by the time they get to me, they've been to the gynecologist and a bunch of other people, including endocrinologists. And almost every patient who comes in here, either when they're making the appointment or the first thing they'll tell me is, if you're going to give me metformin, I'm leaving. I don't know why they don't like it, but it seems, and it's a large percent of those patients. So just be forewarned on metformin. They don't like it. And so usually I avoid it. Spironolactone, like I said, I don't usually use 200 milligrams a day. 25 to 100 is usually enough. And again, it blocks the side effects of testosterone without blocking the effects that we want. And again, the spearmint tea. For hair loss, we're actually doing a genetic test now from a company called GX Sciences. We do get a genetic swab, and it'll give us a formula. It'll give us a hair cream and an oral compounded prescription directly directed towards your patients. I think it's about $150 wholesale to do that, and you can have the patients, you can have it drop shipped to them. We've had very good luck with that. We also used a derma roller on the scalp once a week, and we have them use the cream every night. It has to work they have to use it for 6 months to a year. And again, we have a whole lecture on hair restoration if you're at all interested in that. We'll use finasteride 2.5 milligrams, and I'll use that 3 times a week. We won't use the full dose again because we're kind of fearful of the side effects. Platelet-rich plasma we've used exosomes, and we've used them together. We've mixed the platelet-rich plasma with exosomes, although it's quite expensive. And then we've used melatonin 1% cream nightly, 6 months to a year, and we've had some success with that. But our best success with hair issues really is getting the genetic test and having a formula made for your patient. Again, acne is an imbalance between the androgens and the female hormones, and the premenstrual acne versus progesterone acne. It can be continuous, it can be in the mid-cycle, and so we'll treat it accordingly. Okay, again, to induce ovulation, myo-inositol. Myo-inositol is a combination of myo and D-chiroinositol. It will improve insulin resistance and hyperandrogenism and high androgens. It induces ovulation in polycystic ovary patients. The myo-inositol will restore ovulation, and it is consistent with that, pretty consistent. The D-chiro alone doesn't really work all that well, and it specifically benefits the ovaries. So D-chiro will reduce oocyte quality. So you need to use the combination. So here's just a summary of testosterone excesses. Here are the remedies that we'll use. And this is one of the components of our polycystic ovaries. Spironolactone and metformin, those are your prescriptions. And remember, I warned you about metformin, though. The patients don't like it. And a lot of them will say, if you're going to prescribe me metformin, I'm leaving. So we don't. We like resveratrol a lot, but you need to use high doses on this. The doses in most of the supplements are usually in the 5 to 25 milligram category. You really need 100 milligrams, and you really need trans resveratrol. There's a cis and a trans. The trans is the potent one. The cis is not. Saw palmetto, again, half dose, 250 milligrams on average at bedtime. Chaseberry and black cohosh usually come in different types of combinations. They'll be called flash arrest. They'll be called menopausal arrest, PMS arrest. Those are usually the combinations there. White peony is a Chinese herb that works quite nicely to lower testosterone levels. And like I said, our first go-to is always spearmint tea. Deglycerinated licorice will also lower testosterone levels, but be careful there with high blood pressure. The licorice can raise blood pressure. We use this quite often, though, with patients with GERD. So this is our sort of our go-to for gastroesophageal reflux disease. And then so if they have, we try to, get more bang for our buck. If they have high testosterone and polycystic ovaries and they have heartburn, deglycerinated licorice comes as a chewable, and that works quite nicely. You can also use zinc carnosine in that situation. We talked about NAC and we talked about fish oil. Again, so what we're trying to do is balance our estrogen and progesterone. This is a clinical pearl, and this took me a little time to figure this out. But if your patients are having, estrogen should put them in a good mood. Progesterone is calming. And so patients that are agitated and irritable, and we give them progesterone, remember you dose that at bedtime, and that'll be calming for them. So if their patient's symptoms are during menses, that's an estrogen issue. If it's if it's before menses, it's a progesterone issue. So if the patient's symptoms are the week before her period starts, it's a progesterone deficiency. If the symptoms are during menses, that's her estrogen is not built up, and so we want to increase the estrogen in that situation. And that's a clinical pearl. Don't forget that. You'll run across this over and over again. We've talked about laboratory tests before. If you've heard me, we try to get our laboratory studies in a sort of dead center of our so-called normal. Remember, the normal ranges are usually 2 standard deviations of whatever we're measuring. So for instance, Vitamin D, 30 to 100 is normal. So our dead center is 65. If you add the 30 and 100 together, it's 130. Divide by 2 is 65. That's your center. That's your 2 standard deviations. What we then do is take 1 standard deviation, which is about 68%, at 68.12, something or other. You can look it up. 68%. Break that in half, 34% on either side of our 65, and that'll give us a goal of about 50 to 80. And that's what we'll treat them with. This is your laboratory profile. This is what we do. And again, you can make a lab slip just from here, and this is what we use for the thyroid. And again, a topic for another time. You want the TSH, free T3, free T4, reverse T3, and you want the thyroid antibodies, thyroid peroxidase and antithyroglobulin. Growth hormone, I usually just get IGF-1. Dr. Gordon gets growth hormone and IGF-BP3. They're kind of expensive. Most of the time you can get by with just the IGF-1. If you get growth hormone itself, it's very difficult to get it adequately. You have to get it between 8 and 10 a.m. You have to run the test within 10 minutes of taking the blood from the patient's arm to really get an accurate level. The tube can't be shaken. It'll break it up. It's pretty unstable. So we pretty much go by the IGF-1. LH and FSH will give us, the pituitary sex hormone picture. ACTH, cortisol, AM and PM. I don't do this that much anymore. We use the reverse T3 as a proxy for cortisol. That works quite well. And I used to do the 4-point saliva test on everybody. And again, we don't do more than five a year anymore, maybe 10. It's more for if we're having a problem dosing our adrenal issues, getting the doses at the right time. The reverse T3 is quite adequate. It's about $10, and it'll tell you whether your cortisol levels are off. The rest there, as you can see, the routine CBC, chem profile, lipid profile, C-reactive protein. We do the HS ones. I need to correct that. Again, normal is 0 to 3. Our goal there is less than 1.0. Homocysteine, our goal there is less than 10. Insulin levels are usually about 2.6 to 25. These are usually LabCorp values that I'm sort of rattling off. We want that less than 5. 25 hydroxy vitamin D, we told you 50 to 80. Pregnenolone, that's a hormone of memory, 90 to 110 is our sweet spot there. PSA for men, we want that less than 4. The zinc levels, zinc, and if you get magnesium levels, you need the red blood cell levels. The serum levels really don't tell us a whole lot. And then prolactin we look at also. I'm not going to read these. These are the means, the medians, and the lab values. Again, if you want the slides, I'll send them to Dr. Halassa, and you can have these. This is what we look for. We do this a lot. This is disease risk with normal blood levels. So you get a premenopausal normal of 100 to 110 of estradiol, and you're still at risk for osteoporosis. Day 7 of the cycle, at estradiol level of under 97, and you're at risk for cardiovascular disease, bone disease, as you can see, coronary artery restriction. Menopausal levels, LabCorp will tell you that less than 54 is normal. Patients are at risk for psychosis, postpartum depression, and ischemic heart disease. So how do we tell where we're at? Our optimal time to perform lab studies for our estrogens and progesterones is between days 19 to 21 of the patient's cycle. The first day of bleeding is day 1. We want to measure an estrone, an estradiol, and a progesterone. And for this formula, you don't have to correct for the units. You're just going to take the estrone plus the estradiol divided by the progesterone. You'll get an EP ratio. And our goal is less than 250. Remember down here, if our estrone is elevated, the books tell us greater than 100. If it's over 90, I start getting nervous, and we'll treat them with the 7-keto DHEA. So this chart here, over here, these are the symptoms of estrogen excess. When the estrogen progesterone ratios, as they rise, you'll get more and more of these symptoms. So headaches, sleep issues, sleep deprivation, mood swings, anxiety, depression. Basically, all you need to do is look at this. If it's less than 250, the patients are usually feeling pretty good, and if you're treating them, you've got it locked in. If they're not feeling well, or they're coming to you with a lot of symptoms of menopausal symptoms, they're going to be up in these upper limb ranges over here. I've seen it as high as 7,800 of EP ratios, and the patients are quite miserable. And then when we get them as we get them down, and we can do this fairly quickly. Usually we can get this within 3 to 6 months, and treating them with moderate doses. You don't have to treat them with high doses. We can straighten these ratios out, and the patients are pretty grateful, because the so-called specialists that really don't have a clue. Early on, we didn't get estrone levels, and what we did was we got progesterone to correct for the units. We got the estradiol and progesterone, and we took the progesterone, multiplied it by 1,000, and divided it by the estradiol. Our normal ratio here is about 100 to 500, and I'm just going to show you. I showed you the numbers before. I'll show you an example here in a minute. Less than 100 is estrogen dominant. Greater than 500 is progesterone dominant. Usually, they're progesterone dominant is because we did it. We overdid the progesterone in the treatment. So here's Marie. Remember, so here's her estradiol. If you add them together, so this is basically 0. I'll count it as 0.1 just to give me a number. So 42.1 divided by 0.1, and we'll get 420. Remember 420. Remember 250 is our goal. And so 420, she's in this sort of mild to intermediate range. And this is pretty much what she was complaining about. So you can correlate it back and forth. Here are the medians here. And here's Julia. So the estrone and the estradiol, as you can see here, are quite high, way over the median here. The progesterone is 0.06. Now this could be that we got it at ovulation, and so the levels will be quite low. But she's got all the symptoms of it. Here's her PE ratio of 7,750, and remember we did the PE ratio, so we took the progesterone, multiplied it by 1,000, divided it by the estradiol, and we got 0.22. So again, this is estrogen dominance here. This is another chart that we've used. We got this from Dr. Mark Gordon, and as you can see here, we put in all of her levels here. Here are the ranges. This is sort of the mid range of everything, as you can see here, her prolactin levels are low, her vitamin D levels are low, her testosterone levels are low also. And so this kind of gives us a sort of an overall big picture. I do this for every patient. We have our own chart. I take the lab work so in the morning or before we see them, and I make those charts. This is a 28-day saliva test, and this is the estrogen here, so salivary estrogen. And so you get 11 samples. Usually do it every other day, and you get 11 samples. Remember, you get your peak of ovulation of your estrogen here. You get that second peak in between days 19 and 21, and you get your peak of progesterone here. So this is why we like this here. This is our peak progesterone, peak estrogen. So this is the reason that we do our studies at this time here. If you get it at right at ovulation, you're going to have progesterone levels of basically 0. This was this patient here, and as you can see, the ratios here, they are off. This was Julia, and you can see that her estrogen levels are steady and really high. And then that sort of meandering and then undulation here at days 19 to 21 before it falls off is really off, because we're getting peaks here. You're getting a peak here, you're getting another peak here, and then you're getting a drop off here. And this is going to be your PMS symptoms here. When you have high estrogen levels versus low progesterone levels, this is where the patients are going to get those premenstrual symptoms right in here. So you can pretty much predict it. The saliva test, these are the norms I just gave you this for reference. If you're doing saliva tests, some of my mentors say that the serum tests are not accurate. and they may or may not be right. I've been doing it that way for 20 years. The state of Nevada, where I live, doesn't like serum or saliva tests, so we've learned to live with it. We don't like oral estrogen, so our therapies, oral estrogen only under duress if you've got nothing else. Oral estrogen will, and this is estradiol, will increase blood pressures, triglycerides, estrone, sex hormone binding globulin, carbohydrate cravings, and CRP. It will decrease testosterone, growth hormone, and tryptophan, and it will cause gallstones. Oral estrogens, you'll have increased urinary metabolites and of the toxic estrogens here and here. Versus the transdermal. So to put it all together for our polycystic ovary patients, low glycemic diet, we do a high fat, low carbohydrate, gluten-free diet pretty much for everybody anymore. I'm pretty well convinced that everybody should be gluten-free, whether they test positive or not. I don't see that it does them any good by having gluten, so we try to encourage that. Insulin sensitivity, cinnamon, chromium, alpha lipoic acid, and berberine. You can get that as a combination. There are the doses there. If you want it for weight maintenance, you need berberine 400 milligrams twice a day, 400 milligrams twice a day. They usually come 200, so you might need 2 of them twice a day. Again, high testosterone levels, saw palmetto, metformin, and spironolactone. Try to avoid the endocrine disruptors, anti-inflammatory diet. Green tea extract will also lower estrogen levels. Your aromatase inhibitors are quercetin, licorice, grapeseed extracts, resveratrol, and anastrozole. We still use that in some patients. There's a especially for men, there's a movement to get away from blocking estrogens, but I'm going to talk about that before I finish. Reduced fibroids, uterine size, 1 milligram of anastrozole daily for 12 weeks, and we have done this in quite a number of patients, and it will reduce your uterine fibroid size substantially. Again, resveratrol, cruciferous vegetables, omega-3 fatty acids. Be careful with alcohol and caffeine, of course. Evening primrose oil. So this is what we did for Julia. Again, caffeine and alcohol, no white flour, no white sugar, no dairy. We started out with progesterone creams. The creams are less potent than the oral micronized progesterone. They've been around since 1998. Oral micronized natural progesterone. You can get this at any, there's FDA approved. They're fixed doses of 100 to 200 milligrams. If you need it in between, then you're going to have to compound it. But fixed doses, usually you can get away with that. Nights 14 through 25 of the cycle, we do it for 3 cycles and then reassess. If the estrone levels are high, 7-keto DHEA, we'll do the DIM, 1 to 3 grams. If tolerated, berberine for her blood sugar, and fish oil with an elevated C-reactive protein. So down here, the C-reactive protein was 5.71. So fish oil, if they have joint pain, we like turmeric or curcumin. 500 milligrams, 1 or 2 twice a day. For the vitamin D, again, I told you how to dose that. There is a 50,000 unit one, once a weekly time release one. That works reasonably well. Some patients would rather do that, especially if they're taking a lot of stuff. Homocysteine here at 10.8 is normal, but not optimal. We're going to use our methylated B vitamins for that. And IGF-1, we're going to use a secretagogue, or and we actually use CJC 1295, which is the synthetic Semarelin now. And then we won't talk about the peptides that got canned by the FDA, but we're still able to get them for at least for now. So this is a treatment protocol here. We can, if you want to do a transdermal cream, if you use all 3, so the 2 estrogens, progesterone and testosterone. Anytime you use progesterone, you have to dose it at bedtime. Progesterone is sedating. This is the way we'll start: 2.5 milligrams of bias, so estriol and estradiol, 100 milligrams of progesterone. If they have low libido, lethargy, and some weight issues, we use a little bit higher doses of testosterone. You can do it vaginally or transdermally. If they have Breast tenderness, you want to lower the estrogen levels and raise the progesterone levels. If they have any cancers, we usually leave the estrogens out, although I've already showed you that the patients do better with them. But you live in the land of lawyers, so I try to avoid them. And so we'll use, if they have symptoms of low estrogen, we'll use Swedish bee pollen. Is a good substitute. It's called Relazin. It comes from a company called Bonafide. Or you can use DIM, or you can use the chasteberry black cohosh remedies. Dosing progesterone here, I just threw this in. I know it's supposed to be estrogen, but the FDA approved capsules are 100 to 200 milligrams. Usually we'll start at the 100. There's a rapidly dissolving 100 milligram tablet. The creams, the 200 milligram cream, you're going to have that compounded. You can get it over the counter. You can get progesterone 2.5% to 7.5%, which is equivalent to 25 to 75 milligrams per pump or gram. So if you want to use a lot of cream, you can get it that way also. For vaginal bleeding, you're going to use progesterone for at least 10 days straight until there's no bleeding. Once you withdraw the progesterone, if the powers are with us, within 5 to 10 days, the patient should have a reset and start her period again. If not, we'll wait 28 days and do it a second time. In the interim, though, we'll probably get an ultrasound just to make sure there's nothing in the endometrium that shouldn't be there. Endometrial hyperplasia, 200 milligrams twice a day. You're going to dose the progesterone if the patient is cycling on nights 14 through 25. And we do it continuously. Sometimes we'll do 6 days on, 1 day off, or we'll do 5.5 months on, 2 weeks off. The patients don't really like the hormone holidays, but that it is kind of recommended. So, okay, and again, herbal remedies, chasteberries, the Swedish sunflower oil derivative for progesterone is called Serenol. It's again made by Bonafide. Sex hormone binding globulin can sometimes be an issue. If it's very high, it will bind testosterone, but it will, and so lower testosterone, even though you can have total testosterone levels that are high, if you have high sex hormone binding globulins, the patient won't, it's not usable. So 98% of testosterone is bound to protein, either sex hormone binding globulin or to albumin. You can calculate any website, just put in a bioavailable testosterone and you'll get a calculator on it from any website. If the patient's sex hormone binding globulins are high, you can see the doses up here, 90 or above for females and 50 or above for males. The estrogen levels will be high. You'll have more or severe prostate issues, breast issues, osteoporosis, hyperthyroidism. Low sex hormone binding globulin, you're going to have higher testosterone levels, metabolic syndrome, increased insulin, C-reactive protein, triglycerides, sleep apnea. To raise sex hormone binding globulin, again, estrogens, birth control pills, progesterone. If the thyroid's low, thyroid issues, then make sure you level that off. So St. John's wort, 400 milligrams will raise sex hormone binding globulin. To lower sex hormone binding globulin, we like boron. We start at 3 milligrams. You can go up to 9. Usually 3 is enough, and it takes about 4 weeks, and you'll lower the sex hormone binding globulin by about 50%, about 4 to 6 weeks. I've seen nandrolone used. I try to stay away from those. If you need so nandrolone's a synthetic testosterone, and there's a high abuse potential for that. And also quercetin and stinging nettle will help lower sex hormone binding globulin. Coffee will raise sex hormone binding globulin. And again, losing weight is an issue. Also, to raise sex hormone binding globulin, green tea extract, whole foods, flaxseed oil, certain medications will do it. Danazol, we have used, again, another synthetic testosterone. We have used that. And then tamoxifen and spironolactone will also, and Avista, your raloxifene, will also raise your sex hormone binding globulin. If you want to increase prolactin, again, the antipsychotics, antidepressant agents, morphine, cimetidine. These are just blood levels, or saliva levels, the normal ones and the tests, and then what to do with them. So if you use saliva levels, you can, these are just the dosing schedules for those. Pellets. So pellets have been around since 1972. There was an FDA approved 75 milligram pellet called Testapel. Most of them, the ones we use, are all compounded. We usually get anywhere from 12.5 to 100 milligrams of testosterone for females, and then estradiol 3 to usually 12.5 milligrams. For females, the pellets will last usually 3 to 5 months. If they're very low when we start, a little bit less. Some patients, chew them up though. And I had one patient that every 6 weeks the pellets had dissipated. So we actually abandoned it. It was just to be too much on her. It is a bit of a surgical procedure. And then the side effects are the same as with any excess estrogen, excess testosterone, excess progesterone. The other hormones that we also deal with, pregnenolone is the hormone of memory. Again, 90 to 110 is the blood level that we're looking for. You can dose that anywhere from 25 to 100 milligrams. It's really inexpensive. You can get 100, I think 90 or 100, I think it's 100 milligram pregnenolone from Life Extension for about $15. DHEA, you can get that at a dollar store. DHEA, just as an aside, was FDA approved in 1952 for bipolar depression. So I don't think it's used for that anymore, but it does have antidepressive properties. Cortisol, we look at reverse T3, and we do a free T3 reverse T3 ratio. We multiply the free T3 by 10, and we want the ratio to be greater than 2.0. Melatonin is an antioxidant, an anti-neoplastic. We use that with vitamin D and magnesium taurate 2 hours before bedtime. We usually start at 1 to 3 milligrams for melatonin. The vitamin D would however it was that you figured to get the patient to the 50 to 80 range that we want. And magnesium taurate. So taurate is a sedating salt. Usually comes 400 milligrams. You start with 1, you can go up to 4. You can increase it by 1 every few days. If the patient's too sleepy the next day, then just back off. But usually those 3, vitamin D, melatonin, magnesium taurate, 2 hours before bedtime is a good over-the-counter sleep remedy. Prolactin, high prolactin levels are usually indicative of an adenoma. Low prolactin levels under 6 is indicative of treatment-resistant anxiety and depression. We see this quite often with our traumatic brain injury patients. A couple of other pearls. Remember, we offset estrogen with progesterone. And again, the 7-keto DHEA for estrone. Chasteberry, Swedish bee pollen extract, serenol will raise progesterone levels if you don't want to use hormones. And we showed you that what we did for testosterone. For vaginal dryness, you can use an estriol cream. They do come over the counter. I've seen them at 2.5%. These are the compounded ones, prescription ones, but you can get them over the counter. We use them nightly for 2 weeks. Then we use them 3 times a week for 2 weeks, and then once or twice a week as needed. Works quite nicely. You can also use testosterone cream, especially if the testosterone vaginal cream, if the testosterone levels are low, and that will improve urinary incontinence also. So again, Marie, here's our estradiol levels versus progesterone. As you can see, our EP ratio was 420. And then that was on 226/17 on 5/1. It went to 78 and less than 1.5, and her EP ratio went from 420 to 38. And she went from having hot flashes, night sweats, and brain fog to feeling quite good. The vitamin D level went from 41 to 58. Her homocysteine level dropped by 2 points. Her hematocrit went up by 2 points, and the C-reactive protein went down by 0.5. This is what we did for her. We gave her vitamin D, magnesium taurate, melatonin, just as I told you. We methylated B vitamins for the homocysteine. Again, there's a thyroid component here also. We use plant sterolins, which is Moducare. That's a whole nother lecture. And for the inflammation, we used omega-3 fatty acids and curcumin. For the GI symptoms, we use probiotics, prebiotics, digestive enzymes, and L-glutamine. This was the hormone cream that we put together. I showed you that in the chart. We did try to get her to do some exercise. I'm not so sure how successful we are with that. For the estrogen testosterone precursors, DHEA was low at 77, and so we gave her some. And she had memory loss, so we gave her 10 milligrams of DHEA, 25 of pregnenolone. There's Pure Encapsulations makes a combination called DHEA Plus, which is 25 of DHEA and 25 of pregnenolone. We do use that one quite a bit. So, if you don't want to have it, you can combine them. Insulin resistance. The book says use Ceylon cinnamon. That's $30 a pound here. We've used regular cinnamon. We've done pretty well with that. Again, that's for low level blood sugar, just sort of getting out of hand. Berberine, you can get berberine with chromium in it. It's a little bit expensive, but it does come that way. For urinary incontinence, the patient, after she was on testosterone for 2 weeks, she was able to stop her Detrol. Beriberi vulgaris is a homeopathic remedy. If you can find a liquid form, it works quite well for pretty much any type of urinary irritation, a urinary tract infection. We even had a 1-year-old who had allegedly a dead kidney, and we gave her the beriberi, and the kidney came alive. I'm not sure exactly how that happened. That was maybe 10 years ago. Cranberry works well. And then for the thyroid, this is what we did for the thyroid for her. How are we doing on time, Dr. Halasso? I still have estrogen in men. Let's keep going. Anybody still out there?
Keep growing. It's a great lecture. Keep it up.
Okay. So estrogen for men, estrogen levels are increased due to usually aromatase activity, obesity, alcohol excess, environmental estrogens, estrogens contained in food, liver dysfunction, superphysiologic testosterone levels, calcium deficiencies, and diabetes. Optimal levels are actually 15 to 25 are actually pretty good. Anything over 30, I'll use some of my herbal remedies that I'm going to show you. Anything over 40, we'll use the estrogen blockers, the aromatase inhibitors. I'm going to talk to you a little bit about, there's a big movement, at least in the GG age management group people, to not touch the estrogens at all. In fact, there's one doctor there who lectured, who told us that he takes, one time he told us 8 milligrams. The next time he told us 7 milligrams of estrogen. This is a male. He's in his 60s, isn't he? Stefan, you were there. He's a male. He takes 7 to 8 milligrams of estradiol a day. Sounds crazy to me. And then he does pellets, and he wants his males to be at 2,000 testosterone, total testosterone levels, and estradiol levels at 150 to 175. I mean, in my experience, when the estradiol levels are high, we get a lot of side effects, and I'm going to show you what those are in a sec. So high estrogen levels, increased incidence of heart attacks, strokes, fat, increased risk of erectile dysfunction and low libido. This is what they'll usually come in with, and the estrogen levels will be in their 40s and 50s. Low muscle tone and large prostate, increased breast size. So you're going to get that gynecomastia. Okay, so same thing that I just showed you here. So estrogen levels are cardioprotective in men, but when they get too high, you have twice the incidence of sudden cardiac death. High estradiol levels are associated with acute myocardial infarctions, strokes, and increased peripheral vascular disease. So testosterone levels in men are 4 to 12 per day at age 25. That's how much a male will produce in their peak years. So when we treat patients with 200 milligrams IM weekly, the testosterone cypionate, so if you take 12 milligrams per day, you're going to get 12 times 7 is 84 milligrams per week on average. And so we're giving them 2.5 times physiologic doses at peak years. For females, about 1 to 3 milligrams per day. So 6.3 or 7 milligrams to 21 milligrams per week is the injectable dose. Let me do it. I went backwards. Okay. Super physiologic doses of testosterone will increase estrogen to dihydrotestosterone ratios. You're going to get a decrease in the central neurosteroids. Those are the hormones that are produced in the brain itself. You're going to get a reduction in allopregnenolone, which produces GABA, which is your calming neurotransmitter. Your benzos, remember, your Xanaxes and Valiums and all stimulate allopregnenolone to produce GABA. That's how the benzos work. Although, you know, there's many drug interactions and they're addicting. So there is actually now two. There's an oral and an IV synthetic allopregnenolone that's indicated for postpartum depression. I think it's called Xeroxalone. There's the oral form came out. There's some pretty severe side effects, and it's very expensive. But this is going to be the new wave probably within the next 10 years of treating depression rather than the SSRIs. Again, so you get a decrease in the central neurosteroids, particularly allopregnenolone, pregnenolone, and deoxycorticosterone, which will create a decrease in GABA. And you'll get a rise in glutamine, which is the excitatory neurotransmitter, resulting in agitation, aggression, and irritability. So you also get an increase in inflammatory cytokines, interleukins 1, 2, 6, TNF alpha, and interferon gamma. Gynecomastia is benign proliferation of glandular tissue of the breast. It's an imbalance, again, between estrogen and progesterone. And 4 to 8 months of unregulated testosterone therapy is especially in the vulnerable, what it takes. So what it is testosterone will aromatize to estrogen, particularly estradiol. It is inflammatory, and it is prominent with high prolactin levels, 5-alpha reductase inhibitors, traumatic brain injuries, high insulin levels. With a low testosterone, you'll get a high LH and a high estradiol. It will induce cytokines interleukin 6 and interleukins beta 1. And you'll get your estradiol cascade. So over here, estrogens in men, excess testosterone will fill up the androgen receptors. It will aromatize to estrogen, and then you're going to get ductal growth and breast proliferation. The aromatase triple whammy, so you're going to get estrogenic stimulation is ineffective without anterior pituitary hormones. So those that have adequate growth hormone and IGF-1 that are needed as mediators for breast tissue to develop. Otherwise, they won't. So the aromatase activity will increase with increased body fat and hypogonadism. Sex hormone binding globulin will increase with aging, and sex hormone binding globulin binds less to estrogen than to testosterone. So you're going to get a relatively low testosterone level. You're going to get a relatively high LH and a relatively high estradiol. And you'll, again, so that's going at it about a different way. What to do about it? So predispositions is overweight. Alcohol and coffee will increase estradiol levels by up to 60%. And tight underwear is also a cause of a predisposition to gynecomastia. Other causes are anabolic steroids, certain estrogenic plants, tea tree oil, lavender, estrogenic producing tumors, and testosterone deficiency, usually due to age. Gynecomastia treatment, so you need to they have to stop the alcohol and caffeine. There's just no way around it. They have to watch their weight. If they do not have erectile dysfunction, you can treat them with progesterone 100 milligrams at bedtime with some DIM. If they do have erectile dysfunction, we use the anastrozole, the estrogen blocker, in a low dose, like 1/4 to 1/2 milligram, 1 to 3 times a week. We'll use some DIM, 100 to 200 milligrams daily. Decrease the testosterone dose if they're on that, and you can use a DHT cream or a progesterone. I prefer that. I use that right on the breast tissue, the over-the-counter 5% once or twice a day, and it's quite common that unless it's embedded, that the gynecomastia will regress. Here are the references for all that. You can, again, and aromatase inhibitors that we use anastrozole mostly. It's really cheap. You can get 30 of them for about $11 or $12. You're going to use a half to 1 milligram. They come 1 milligram pills. You get 30 of them for about $11 to $12 at a supermarket pharmacy where I live. There's some other ones you can use here: letrozole, exemestane. I don't know what the costs are on those. Off-label aromatase inhibitors, again, spironolactone and metformin. And then there's this big movement again at AMMG to not block estradiol. They kind of cherry pick what they're presenting and saying that this is it. So, but here are some aromatase inhibitors side effects. So again, if you're blocking estrogen, you're going to end up with low estrogen. So what are you going to end up with? You're going to end up with thinning of the bone, hot flashes, night sweats, again, brain fog, breast tenderness, breast swelling, numbness and tingling in your hands and feet. Again, circulation problems. Remember, we talked about that before. Body aches and body pains, difficulty sleeping, anxiety, depression, difficulty moving your fingers, high blood pressure, and you can even have strokes. I mean, I've never seen any male have a stroke from taking a half a milligram of aromatase once a week. These are the symptoms of low estrogen, and again, this is what they kind of harped on here. Again, osteoporosis, fatigue, mood swings. These are symptoms of low estrogen. Cognitive decline, vascular insufficiency. I mean, if you use high estrogen blocking levels and get the estrogens down to 0, you're going to see some of it, and that's what we did see, especially the cognitive issues and decreased libido. But if you keep the high, not too low, I think you're pretty safe. Low serum estradiol levels in men are associated with low bone density and increased incidence of hip fractures, and elderly men that have hip fractures have a 37% mortality rate 1 year post hip fracture. So it's not good for these more mature guys to get to have osteoporosis. So cardiovascular disease, higher serum estradiol levels. Some of the books I showed you earlier said that you get higher incidence of cardiac disease, and then there's some that will tell you they have lower incidence of cardiac disease. So I think the jury's really out on it. Low dose supplementation with estradiol will lower blood pressure, and it will raise HDL cholesterol, by the way. That is a given. And physiological levels of estradiol are associated with adequate levels of apolipoprotein E and blood pressure regulation. So the bottom line, I think, is you need adequate estrogen levels, you need adequate testosterone levels. Don't go overboard either way. Not too much, not too little. Cognitive function, again, estradiol deficiency accounts for increased body fat, decreases blood flow to the brain, decreases memory, concentration. It could also lead to poor sexual performance. But too high estradiol levels, and we've seen that, and that's one of the complaints. And we see guys with estradiol levels in the 50s, 60s, 70s, and we lower them down to the 20s and 30s, and the erectile dysfunction it resolves. Higher estradiol levels have longer telomere length, which is your biological age marker. And lower estrogen levels correlates with obesity. So this was one of the main studies that the folks who talked about this stuff cited for the reason not to block estrogen and to just let it rise. But if you look at the data that they actually present, I think you'll come to the opposite conclusion. So the lower the estradiol levels, the higher the estradiol levels, the more you had ejaculatory issues for men. So delayed ejaculation when the levels were at 70, premature ejaculation at 91, and erectile dysfunction at 109 with the controls at 91. So increasing the estradiol levels, you get a distribution value from delayed ejaculation to erectile dysfunction, and that we see that all the time. And this next one is for osteoporosis, for hip fracture levels. And again, low levels of estradiol, you see low. So our sweet spot usually is about 15 to 25, but down around 2, 3, 4, you're going to have higher incidence of hip fractures. But as you can see in the mid-range here and high, the incidence is pretty much the same. So, the idea that they say, well, it causes osteoporosis. Yes, if it's very low. This is just a summary of what happens with estrogen in males. And it looks at pretty much every tissue. So direct heart protection protects against ischemia. Its liver is the site of estrogen metabolism. Kidneys maintains phosphorus and calcium production. The skin turgor it stimulates collagen. The genitals, it inhibits sexual activity in males if it's too high. It inhibits spontaneous erections if it's too high or too low. Bladder, you get your estrogen androgen ratio is for your benign prostatic hypertrophies. In the GI tract, it protects against irritable bowel disease, ischemic bowel disease, and the spleen. It increases the size and it preserves red and white blood cell function. So let's see. Here's remedies here for estrogen. Again, if you don't want to use estrogen blockers, again, vitamin D to an adequate level. For this strontium, we'll use this for osteoporosis. And resveratrol, cranberry, spearmint tea will control testosterone levels. Deglycinated licorice will, omega-3 fatty acids, and chrysin, zinc, flaxseed oil, zinc, 30 to 50 milligrams, DIM, phytoestrogens. This is just a chart of estrogen deficiencies. The main ones are hot flashes, night sweats, brain fog, belly fat. Estrogen excess, remember, causes cysts everywhere, and gallstones. Gynecomastia in males. This is a little quiz you can use for, and I have this for all the hormones, but this is the one for estrogen here, 0 to 4. You can use that as a quiz. And then so you decide, estrogen, devil or angel. Questions? So
very good.
Good lecture.
Yeah, absolutely. Let's see. Let me turn my volume up here.
Okay, so we got Mike from National Pharmacy. We've used you already.
Yeah.
Got to update the estrogen metabolism slide to include iodine. You're right. I'm a little bit behind. I'll fix that.
I got to give you my lecture on that on your show.
Okay, you will. Will I share
Have
this?
a quick.
I can either send them to anybody who sends me. I'll give you my email address, or I'll send it to Dr. Halassa, and he can send it to everybody on his list.
Absolutely. Yeah, that's a great lecture, Dr. Clearfield. We've heard that. I've heard that more than one time, and every time I hear it, I hear 10 things I didn't hear the first time. And I think this just shows why, seeing these things over and over is really important. Plus, you adding new things here and there. So, I think we should all see this once every 6 months or a year. Just to it's just like a good movie. You always see something more in it that you didn't catch the first or the last time because you weren't thinking about it.
I've gotten interest from two places, one in Canada and one in Australia, that want me to redo all these lectures. They're naturopaths, so they want me to take out the prescription and just treat with natural.
Yeah,
so
that makes some sense. That might be the most sensible way to arrive at a naturopathic formula. Is to kind of show it in comparison to what the medical protocols are and let them kind of decide where they want to use each.
Mm-hmm.
Yeah.
Why do you use 7-keto DHEA if the estrone is greater than 90? So the 7-keto DHEA will displace the regular DHEA and it will disrupt the estrone metabolism. It will decrease it by about 50%, about 4 to 6 weeks. So remember, estrone is that's your cancer pathway. So we try to avoid that. Okay. After 12 weeks. Yeah.
Yeah, I've got a quick question here. Actually, You know, it's funny because, like you said, it's like you hear it again. I mean, that was an enormous amount of information, and I thank you for that because it's really stimulated me to get back into trying to do my independent learning with these concepts. And sometimes I realize sometimes I just don't actually know things. One of the things I'm still trying to wrap my head around, and it's almost embarrassing, is estrogen disruption. And for some reason, I seem to turn it around in my head. Like is it blocking estrogen, or is estrogen disruptors increasing estrogen and creating that imbalance of estrogen
Recording in progress.
progesterone?
The answer is yes. It could go either way. For the most part, you'll end up with estrogen excess.
Okay, and this
with the endocrine disruptors, that just seems to be the way they're designed.
And okay, and this is coming from the BPH. This is coming from the chemical toxins, the exposures. That's the whole reason why women are having polycystic ovarian syndrome, is literally coming from these toxins.
And this is my own personal opinion. I think the birth control pills, especially the young girls, they have headaches when they're 12 years old and they give them birth control pills. I think early use of birth control pills seems to contribute to that also. So that's just my opinion. By the time I get them, it's too late to do anything about that. So
no, I think that's excellent intuition, because it's like obvious. You know what I mean? Why would so many women have, like, for example, the gallstones? It dawned on me all of a sudden. I was like, wait a minute, estrogen, too much estrogen. It's like anything that's too much estrogen causes overgrowth of anything. So like fibrocystic breast disease, or uterine cysts, or gallbladder stones. Too much estrogen, it's like that balance is off, because progesterone counterbalances the estrogen. Is there anything more to the gallbladder situation that you can think of? Do you think it has to do, maybe, I mean, obviously there's more to it. There's the obesity and inflammation, but could it really be mostly due to the overuse of the oral contraceptives?
If you catch the patterns, you're going to find that it's too much estrogen. The patients will come in and they have spotting between periods. They're 40 years old. Their periods are irregular. They have a lot of pain. The pain, and they have the vasomotor symptoms, what some of the books call it, during their period rather than the week before. And then they have breast cysts, and they have a fibroid or an ovarian cyst or endometriosis. And I had my gallbladder out 10 years ago. So if you recognize those patterns, you're that much ahead, and you've really built some credibility with your patients too, because usually by the time they get to one of us, they've already been to 3 gynecologists and an endocrinologist and the Reiki master, and they went to the ashram and you're my last hope. I'm sure you've heard that one too.
Sure. No, and I really do like it when it gets more clear. I mean, I haven't dealt with these specific. I haven't attracted a lot of patients for these issues specifically. I get them for different issues, but this is still going to be tied into it in some shape or form if they're female. And I was just what was it? I was going to mention, you had talked about using ketoconazole, and of course I did that lecture a couple of weeks ago on fungal overgrowth, and I was thinking about it because the flora, just like the microbiome, we've got a skin biome, and you can have fungal overgrowth of the skin, which is probably a lot more common than we think, especially with the amount of lymphopenia nowadays, especially that I see on the lymphocyte maps, that this fungus, this melasthesia fungus that we were talking about, it requires fat. That's why it likes us so much. It cannot create its own fat, so it has to feed on our fat. And so I was thinking, as I was putting things together with some of the issues with the hair loss and the acne, that the skin was becoming too oily. Is that another? Am I seeing it right? The connection between the too much estrogen, maybe producing too much oil, and that might cause the overgrowth of the fungus because it loves that oil that overgrows. It causes that inflammation that leads to the acne, that leads to the inflammation, gets into the hair follicles, which leads to the hair loss.
Well, there's usually some insulin resistance in there, and so the increased blood sugars, and that whole cascade also that will lead to that.
The insulin resistance.
Mm-hmm.
I'm trying to connect that. Also, so the insulin resistance may be leading to the obviously increase in blood sugar, leading to probably weight gain, leading to excess oily skin, maybe.
Yeah.
Okay.
Decreased blood flow into the skin. Depending on where you're looking, if you're looking in the scalp, you're going to get an increase in dihydrotestosterone, which chokes off the hair follicles and decreases the blood flow to the scalp at the same time.
Okay. And then the other thing that I was trying to sort out in my mind was, then why does the testosterone level go up for the women? Because obviously that's causing the increased hair growth. I guess that's part of the polycystic ovarian syndrome. Right. But I'm not seeing where the testosterone is. Why? I could see the estrogen dominance leading to the polycystic part of it, because I mean that's what it does. It just overgrows. It causes cystic everything. It seems like estrogen dominance. But then why does the testosterone
is what's
increase?
It's the excess testosterone that's causing the increase in estrogen.
It's the increased testosterone that's causing the increased estrogen.
Yeah. Decreases insulin, decreases sex hormone binding globulin, increases circulating estrogen. Insulin and LH increases androgen in the ovarian cells, and then you get decreased hydroxylation of the 2-hydroxy estrone, the good pathway. You get an increase in estrogen from too much of the testosterone, from increased aromatization, and then that's where the estrogen dominance comes from.
So, okay, so there's that decreased sex binding hormone. So I didn't see from that. That was a great slide, by the way. But I didn't see. Was it the increased insulin that was leading to the decreased sex binding hormone, and then that causes a rise in the testosterone because I guess it's not being bound up? Is that sort of the probably the understanding?
Yep.
Okay.
Got it.
Interesting. No, this is fascinating. Thank you.
What we do, right, John? We connect the dots. So, being chastised here in the chat by Stefan Hartman to use it iodine 50 milligrams. 50 milligrams. That's a lot of iodine, isn't it?
Yeah, use it if you got cysts. Use the iodine.
And for high estrogen, you use pure encapsulations, dim detox. Okay.
Yeah, it works very well. 2 capsules a day. It's super potent. Sometimes they'll even get hot flashes if you do too much of it because it suppresses them so much.
Okay, well. Okay.
Hey, can I ask something of this crowd tonight?
Sure.
Is Bill the king or what?
I don't know, but king of what?
Of the hormone world, Bill, you have really gone deep.
Thanks. Just to let you guys know, tomorrow night on our show, we have Mark Gordon. So don't miss it. He's the king. He'll tell you he's the king. I won't tell you that. So,
not everybody knows this. I was talking to our leading stem cell people in California today, and I asked them, and they were talking about traumatic brain injury, PTSD. And I said, do you know Bill Clearfield? No. Do you know Mark Gordon? No. And I said, man, it's like coincident. Mark Gordon is talking tomorrow, right?
He's talking tomorrow on ours.
Yeah, that was weird. But here they don't know who the real experts are, but they're acting as experts in California. And they didn't know if I was crazy or not, but who knows?
Okay.
But
So
anyway,
if anybody needs the link for tomorrow night, if you're interested, just send me an email, drbill9@gmail.com. And if you guys all talk, I'll go find it somewhere. So talk amongst yourselves. I'll be back in a sec.
There you go. Let's
I'm
see.
Mike Bomer.
Hey guys, how are you? So,
Doing good.
hey, Halasa, will you let me share my screen? Or if you can give me, but yeah, I hope everybody's doing good. Okay, it's not gonna work. Yeah, things have been going pretty good. And I noticed the groups continued to function here a little bit as I haven't been around, and I appreciate that. So I thought that was a great lecture. I love to hear about the hormones, and you know, again, I just learn something new every time I hear that.
Okay.
Bill is just getting better and better. It's so much information.
It is. But see, the thing I like about it that makes it different, maybe you'll agree, Dr. Burgess, is that it's come from his personal observations of his own practice and probably literature learning too, but it's got a practical nature to it. It's not something that somebody dreamed up that they never did before. It's so the hand of the person that did it. And to me, that makes it a lot better.
Okay. So
Yeah, totally agree.
here's the link for tomorrow night, 8 p.m. Eastern, 5 p.m. Pacific. And Dr. Mark Gordon, he's going to be talking about neuroinflammation. So
There we go.
Maybe I can let you share the screen. I'm not sure. Multiple. Okay, try it now, Mike.
Let's see. Oh, it'll work. Here, I'm just going to show you guys this real quick. Probably showed you this before. We're launching this thing at A4M. It was the thing that Dr. Klatz and I did. But look at the ingredient list here. This is going to be something I think everybody might like. I don't know if you can see this. Let me make it bigger. Let's see. I can't see what's showing on. All right. This ingredient list here is a lot of stuff for a pretty reasonable price. We tried to get everything that we could that we're talking about at A4M and all of our groups into one supplement that can serve as a basic supplement and reduce the pill volume that people are having to take. So this is going to get introduced. It was something we were working at with Amex before things went down the drain there. And, you know, I just, since we had a quick minute, I was going to point out that a lot of the things that Bill's talking about are in here. And it's just something you could give to anybody, basically. We've tried to omit anything that shouldn't be there. But, you know, just for the lecture tonight, we heard about resveratrol. We got 150 milligrams of that. Curcuminoids, that's the Sabinsa C3 curcuminoids, 200 milligrams. Well, you could go down the list. Methylfolate, methylcobalamin is methylators.
Is this a 30-day supply?
Yes. Yeah. Yep. So it's basically $99 a month to the patient, or you could get them if they buy 6 at a time. They get them for $79 a month, which is really a good deal. And the doctor's making $30 to $50 a bottle on that. So we're hoping that people will get on board with it and find at least a few patients that would benefit. And it would help reduce those people's pill burden and costs, because I did several things with the Lyme disease group over the last Lyme disease and people treating a lot of Lyme disease. And I started to realize how many supplements these folks are taking and what their costs are like. And it's hundreds and hundreds of dollars to get on all these things. And so we started thinking, what can we do to pack as much stuff that's sensible into one supplement? So, you know, it kind of covers the mitochondria, it covers methylation, nitric oxide, detox, you know, all your B vitamins, just all your metabolic support. It's all in there, man. And we've been really careful and reviewed it a million times. So I hope it doesn't have anything objectionable too. That's been a big, area of concern that we try to avoid anything like that. Anyway, just throwing that out there. I'm not trying to make a big sales pitch, but I just want people to know that's out there because I think it's a good value and it can be a little money maker for you.
This is great. And I must compliment you on a decent dose of iodine, 1 milligrams. That's more than any other multivitamin out there. Very, very good on that.
Well, that wasn't by accident, Stefan. I do listen.
Minimum. I tell my patients 3 milligrams minimum, but one is, if they can get 1 a day, that's good for me.
I try to keep it without, and we could add to that, but I try to get everything in the area where it had it in there, but not too much where one person would be unhappy. And I also made them assure me the NAD's potent, you know what I mean? The NAD will have potency, so we'll find out about that. But my feeling is NAD works better than NMN, and if we're getting any of it, we're better off than
how are you getting NAD bioavailability here?
The manufacturer is claiming that, so my feeling is it can't hurt anything by having it in there, and it doesn't cost anymore. So why not give it a try? I have pure NAD powders to find. And you know what I do is I put it in the Quicksilver or not the glutathione, that have to have their NAD formula, but it doesn't have any NAD in it. It's like got NMN. I just take NAD powder, put it straight in that, put it under my tongue. It works great.
It works, huh? Wow. I always learned that it didn't work.
I know people tell me that too, but try it and see what happens.
All right, I'll try it.
Yeah, I'll let anybody try that. I was surprised. So that's the only questionable thing in there to me is that one. But at the very least, it's it's not harming anything. You're getting some.
You got selenium in there too, it looks like.
Yep, selenium. We were very close. And that's actually selenomethionine, which is the favorable version of that, because you're also getting it's just a better, more bioavailable. It's an organic form of selenium.
Yeah, this is great. I'll stock it in my office. Just send me some.
Yeah, man, everybody can, and willing to drop ship it, so you don't have to pay anything. But anyway, that was our little thing. We're going to be introducing that soon, so I'll get out of your ear on that. Let's see when we stop.
How big is the pill, Mike?
Huh?
How big is the pill?
They're size 0 capsules. It's 4 a day. There are 4, so it's 2 in the morning and 2 in the afternoon.
Okay.
So it does take 4 to get all that stuff in there. That's a lot of stuff, but it's 1 bottle of pills for 1 price. That's the key. You can't get it down to 1 pill; it just won't fit.
Okay.
It's just impossible.
I'll sell this. This is good stuff. They need all this.
Yeah, everybody. That's where we're shooting for. Is what is the best thing for all of our patients across the board? You can have, of course, to add to it, like Bill's protocols. If you have polycystic ovarian disease, you're going to need other things, or each of you are going to instruct your patients to add a thing or two. But at least you're not. Now you've got 3 things to take, not 12 or 17. So
this is good. No, they need something comprehensive like this because they're not doing anything. They need to do this.
Well, the other option is at least you can tell them one thing, and they really can't get anywhere but you because no one else will have it. You know what I mean? That's the other thing. This is only available through you guys. So, it's not like Walmart's going to have it or Amazon's going to have it. So, at least you're going to keep that connection with your patient. So I don't know.
Mike, did you call the number that was located on that slide you just showed us?
Yeah, that's a bad number. I know.
Oh,
that's actually a bad number. That really is. That's the old Amex number. So, so we'll launch this. I'll put it back on here. But we're going to launch this at A4M. We'll have a booth. We're going to share a booth with Muscle and Fitness. So, Stefan, you can come and do your interviews with Muscle and Fitness folks. I think it'll be a good time. They usually have. I wouldn't backtalk any of the young ladies they have in their booth. They look like they could break a chair over you or something. But there's some very athletic people in that booth. But you might even meet some other cool people. I think they have some celebrities stopping by and all that kind of stuff. So it could be fun.
Yeah, I'll see you there.
Yeah.
Are you telling me something is happening with Amex Pharmacy?
Maybe I have, the board hasn't got out, John, maybe to everybody. The owner, Amex Pharmacy was owned by a parent company called Pacifico National. And Mark Sangre was the owner of that. He passed away suddenly. And so because of that, the company, we didn't know, of course, was insolvent and had been sucking money out of the pharmacy, you know what I mean, to keep the parent company alive. And it resulted in the whole thing going out of business, like literally overnight. And so when he passed away, the heirs saw what had happened and they shut it down. Literally, I had 24 hours to clear out of the pharmacy. So now Wells Pharmacy has come in, they're going to come in and reopen it, but it'll take a couple of months for that to happen. That's kind of a bit of a process of licenses, inspections, and all kinds of all kinds of fun. I can help anyone. We could share stories on that. But
So are you going to stick around there and do your
absolutely, I'll continue to run that facility. It'll be a bigger, better facility than before, with a much better funded company, probably about 20 to 30 times the size of EMX. So now we'll have things like peptides and injectables and 503B, everything. So it'll really help our group because we're getting tied to a much bigger pharmacy. And we also still have Mike supporting us, who does a great job in California, which guess what? Wells doesn't ship much to California, even at their size. They're like, you got to be in California. It's just that's just part of the deal. And I think there'll still be room for other options for, because some of the smaller things they may not want to do, and we're going to need other pharmacies to work with those things too. So yeah, but I will still definitely be involved with all of that.
Okay, that's wonderful. Sounds
Yeah.
great.
So you can't get that bill until you get set up. Is that what?
Yeah, exactly. I
Okay.
mean, here's another thing I learned about Wells. Some of these big compounding pharmacies prioritize their customers because they have trouble getting orders out. They're so busy. And one of the goals I'll have is to get our group bound together as a group. So if you order, you'd be a member of this group and you get like VIP service. Your orders ship like 5 days faster that way.
That's good.
You know what I mean? But if you don't ask for that, or you don't have enough people, like prescribers, they'll be like, well, why would we? You can't be a VIP unless you're like, or more, you got to have more business. So I think if we all all you'd have to do is click that box when you signed up for their pharmacy, and all of a sudden you would get that service just automatically. So that's something I'll try to set up with them. I didn't realize that was going on that way.
I got a quick question. And this one is like totally different here because it's just been on my mind. I've been looking into L-Dopa, and I'm not talking about the prescription L-Dopa for Parkinson's, but the plant extract, I guess, that is more, I would say, bioidentical to, it's the precursor of dopamine, because I'm starting to see that as a great straightforward target for patients dealing with fatigue, or especially the variant that's going around for COVID really is causing that same fatigue. And I know selegiline is great in the sense that it's a MAO-B selective inhibitor, so it keeps the dopamine around. But I was looking for a way to also produce more dopamine, and I realized that this L-Dopa extract, bioidentical L-Dopa, might be something that the compounding pharmacies could produce, and I think that would fill a huge niche, especially for people maybe who aren't younger patients who are not ready for selegiline, but they need that. I get this complaint all the time. Patients who say, I feel like I just don't have any dopamine in my brain. Any comments?
It's been depleted by social media.
Yeah. But it's physiologically, I believe that dopamine levels are down.
You're probably right. What we should ask cardiologists, what are the risks? Isn't dopamine like super cardiotoxic? So, I mean, I'm wondering if it's not best to, like what your approach with the selegiline seems more sensible to me than using a dopamine agonist, is my point.
Well, no, this isn't a dopamine agonist. L-Dopa is the precursor to the production of dopamine. Now,
Right.
I do like the idea of selegiline on board because it does reduce oxidative stress, because it's decreasing the breakdown of dopamine. So in general, for people like us, I think selegiline, and then if selegiline is not enough, then we can add L-DOPA. But I'm thinking the more I look in, it's another one of those things where if you have the repurposing mindset and you realize, wait a minute, it's not all about Parkinson's disease, like DMF, dimethyl fumarate. It's not all about multiple sclerosis. I mean, it has like multiple systemic benefits.
I agree with you. Well, it's just like using DHEA and clomiphene, right? You're feeding a system and you're pushing the system at the same time. So, in other words, if you give DHEA to produce, as a precursor to testosterone, and then you stimulate the testes, then you're going to make more testosterone naturally. The same thing what you're talking about with the neurons, right? You're saying I'm going to use the selegiline as a blocker for dopamine, and then I'm also going to give a precursor to dopamine on the front side. That makes sense.
And I'm also seeing that helps with libido, because libido is becoming an issue. It may actually help with sperm production. That's an issue. And I think, I'm going to look into doing doing a talk on it and getting a bunch of articles and tying some of these things together and showing the evidence. But I guess, again, my question is, do you think L-DOPA is something that can be compounded?
There's something going on with it, and it induces its own metabolism. So I remember they have that whole thing about carbidopa and levodopa. I'd have to learn about it again, but I think L-DOPA induces its own metabolism, and they put the carbidopa with it to prevent that.
Well, the difference is my preliminary understanding of it is that the L-DOPA that we get, the synthetic, is, of course, there's always something about it that makes it
a little different.
There's that downside. And the other thing is it's also more sort of like pure, versus when you get this sort of plant extract, you're getting like a percentage of like maybe 10 to 15% of L-DOPA. So it becomes something that if you're treating Parkinson's, you need like the maximum or the optimal dose. If you're just trying to have more energy, I'm talking about actual energy, like
I get your point.
Your memory, you take it, it works. Not, I think it's working, maybe it's working, maybe it's not. I'm talking about something that actually there's a physiological loss or deficiency of it. And anyways, what's my point? My point is that when it's compounded more in its bioidentical form and maybe in its plant extract form, it's not going to have that side effect where you need that carbidopa to for the decarboxylation process, to prevent that side effect, which I'm still kind of have to go into the mechanisms and learn those. So having that sort of more bioidentical approach to L-DOPA, it's just like having bioidentical testosterone or estrogen or progesterone. It's not going to have any of those side effects where you would need carbidopa. You know what I mean? That's what I suspect. That's what my intuition tells me. If we were to go down that road, if it turns out that could be compounded, I think that might actually go along very nicely with the selegiline.
Yeah, and when I look here at alternative treatments for L-DOPA, guess what you get? Monoamine oxidase B inhibitors.
Oh, yeah, well, and the thing is, you can use both of them together, and that's what they were doing for Parkinson's when with the book that was written in 1990, when Deprenyl was sort of, they were trying to bring that out of the, and
the other one to look at is ropinirole. Have you looked at what's called ropinirole?
Well, I mean, I have one patient who's on it, and that's for severe, like the
those are the only ones that kind of
hold on. You're not hearing me. The genetic form of the restless leg syndrome, the severe form, not just the I wake up in the middle of the night with muscle cramps, like the kind where, you know, you have to like it severely disrupts your life because you have to walk it out for like an hour and a half. So ropinirole is really, it's like when my patient takes it, as soon as it wears off, the restless legs come right back. It's too much like a push button big farm drug, whereas the natural form of L-Dopa can be something that you have as needed to go along with the selegiline. So if you need a pick me up, you just pop an L-Dopa and you're good. You see what I mean?
Yeah.
If you don't need it, you don't take it. So it's an added layer to the selegiline.
I'm sure you could do it. Yeah, I'm sure you could do it. You could do like an L-Dopa sublingual lozenge in a very low dose, you know, like 10 milligrams or something, or 20 milligrams or something.
And I'm seeing this is the replacement for Adderall for our patients, because Adderall is getting harder and harder to get. Number two, it's not healthy. Okay. And like I said, if you're looking for alternatives for Adderall, sometimes you're not going to get the full effect of an Adderall with selegiline. Although selegiline will take the edge off. Like I stopped taking the Adderall because I was just tired of it. I was tired of, you know, always having to have it refilled and all that stuff, because you have to have somebody else write the script for you, and you know, yada yada yada. And the selegiline was great. Actually, phenyl. And the great thing is some of the supplements that increase dopamine, or like a phenylethylamine, they're much more potent in the presence of selegiline. Okay, so it's like because MAOB, I think somebody's dog is making noises. I don't know what it is, but the MAOB also breaks down phenylethylamine. Prevents. Oh, yeah, it breaks down phenylethylamine. So when you block MAOB, the phenylethylamine sticks around. And so if you take a phenylethylamine, you feel it. You know, it's a supplement where it's like, wow. And so I was surprised that I was able to stop the Adderall and just, I didn't need it. And the selegiline, and I would take the phenylethylamine as you know, it kind of upsets the stomach. So that's why I was looking for an alternative. And the L-Dopa, the plant extract part, that really, I don't know. My spidey senses are telling me that there's something here that could be that really could help, especially the patients who are getting off of, or maybe that there's not enough Adderall, or to trying to get into a more natural way of helping their concentration in the presence of all of these factors that are causing it to be decreased.
I get it. I think that's a good approach.
Yeah. Anyways, so all right. Well, we'll just I'll ponder on this some more and present the lecture if I really do have the big, you know, if what I'm thinking right now seems to be the case. I'll put it out there and let everybody else be the judge.
Sounds good. Well, I know Dr. Halas is in Libya, so he's signed up long ago. It's like 3:30 in the morning there, something's probably. But Dr. Bill, thank you so much for coming to our group and making this wonderful presentation. And
gave you the link for tomorrow night for us. We have Dr. TBI, you know, expert.
Yep. That's a fantastic lecture, and TBI is going to touch all of our lives as we ourselves age and watch those around us age, and the people we care about. And these are serious things. And, you know, boy, if you can jump right on them, like what I'll bet we're going to hear tomorrow, when you really get the right treatment right after the incident, there's a lot to be gained from that. I bet that we're going to learn more about that. So
you all for inviting.
Yeah.
I got lots more if you need it. So, okay.
Yeah.
See you.
Sounds great.